Hi, and welcome to the Muslim Sex Podcast. This is Dr. Sadaf Lodhi, and I would love for you to leave me a review of this podcast and also to share and like it and share it with your friends, see what they think, and let me know. I would love to shout you out on social media. And also, I would love for you to follow me on Instagram at Dr. Sadaf OBGYN, as well as TikTok. I also have started a YouTube channel at Dr. Sadaf Intimacy Coach. I'd love for you to follow me on all of those channels. And most importantly, I'd love for you to become a patient. I am now accepting telehealth patients for sexual health as well as menopause health in New York and Michigan. So if you are a woman that is looking for a doctor that understands you and can actually take the time to listen to all of your concerns, reach out to me. Reach out at Dr. Sadaf at drsadaf.com. And I would love to see you as a patient. And now for the episode. I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodhi, and this is everything you need to know about polycystic ovarian syndrome, otherwise known as PCOS. But before I get into it, the first thing I want to make very clear is I'm not giving any type of medical advice. So if you have any healthcare issues, please speak with your healthcare provider. And if you have any religious issues, please speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So welcome again to the podcast, Dr. Faris. I'm so happy to have you on. You were on before discussing nutrition and nutrition as we age. And now we're going to be talking about your new endeavor on polycystic ovarian syndrome. So, welcome back.
Thank you. Thanks for having me back.
Yes, it's my pleasure. So, maybe you can, for those individuals that may not be familiar with what polycystic ovarian syndrome is, perhaps you could let us know.
Sure. So, as you already mentioned, PCOS stands for polycystic ovarian syndrome. And though many people argue that this is actually not a great term for what it is, that's the term that we use currently. There's some debate about changing the name. But basically, polycystic ovarian syndrome, or PCOS, is a complex hormonal disorder that affects people with ovaries. And it has many different organ systems that it affects. So it affects people's menstrual cycle by interfering with ovulation. It is characterized by having elevated androgens. So these are the hormones that people think of being male hormones, but they're not because women have and make androgens too normally. But having an excess of androgens have certain side effects on the body. And also, for most people, it's characterized by some metabolic abnormalities like insulin resistance. And so it affects many different organ systems. It affects people's cardiovascular health, their reproductive health, their mental health. And so that's part of the reason why we're talking about it today, because we're going to get in a little bit into the mental health implications that it does have, and implications on sexual health. And um, but uh, yeah, that's pretty much it. And as you mentioned before, we've already spoken about nutrition and women's health, and this is really an area where nutrition can have a large impact in the outcomes of polycystic ovarian syndrome.
Well, that is amazing. And I'm so glad that you focus on this because I think a lot of OBGYNs, we have a little bit of knowledge, right? We have a little bit of knowledge about a lot of things in dealing with women's health, but, very few of us will take time to delve into it and really get to know the nuances and really what's important for women that have polycystic ovarian syndrome. So I'm so glad that you have taken this on and have really delved into this topic because, as you say, nutrition plays a huge part in this syndrome and can probably really help. And you'll definitely, I'm sure, let us know about that. I
Yeah,
also like the fact that you mentioned this effect of the syndrome on mental health. I think that's huge. And it's something we don't talk about at all. As you
correct.
are well aware, we don't talk about mental health in general, but really what this syndrome can do and what it does to a relationship and how I was just talking to somebody this morning, and she was telling me that she had a friend that has PCOS and is really afraid that she's not going to be able to get pregnant when she wants to get pregnant because her cycles are all over the chart and she doesn't really understand what's going on. So, I think that this is a very important topic.
Yeah. So as yes, we all, just in the same way that we did not receive that much education around sexual health for women in our OBGYN training and many other topics, one would
Mhm.
argue. Yeah, this is one area that I feel that my training didn't necessarily prepare me for. But I think it's really important. It affects 10, depending on who you read or which source you're using, somewhere between 10 and 20% of women and people with ovaries are affected
Wow.
by polycystic ovarian syndrome, which is a huge statistic.
Yeah.
So
It's
that
huge.
means if you're seeing patients in your office and you're seeing 20 to 30 patients, you're seeing somebody with PCOS every single day. If you're,
Yeah.
if you're an OBGYN or even just a primary care physician. So
Yeah.
you're seeing it every day.
Right, right. And so that's why it's so important for us to know how best to treat women, because I think the mainstay of what we do as OBGYNs, to be honest, is that when a patient comes in, she tells us she's having irregular menses and she's not looking to get pregnant. What do? We put her on birth control pills, right? Just to regulate
Correct.
her cycles, and hopefully that'll deal with, her issue, and hopefully she won't come back until she's ready to get pregnant. So I
And
think
that's
that
true. That's very common. That's the approach, but many women complain that that is the care that they're receiving. And not to say that putting somebody on hormonal contraception for PCOS is wrong, because it's not. It's definitely very much part of our management.
yeah,
It's the lack of testing and
yeah,
the lack of education that is what is problematic, right?
right.
So we need to be confirming that that's the diagnosis or excluding other diagnoses, and we need to be educating. So because as the patient, the person that you were speaking to this morning, right, she doesn't know what's going on with her body, and that's just from not having the knowledge that she needs. So
And I agree. And I think that, kind of what you said is that we don't get very much instruction on PCOS or really how to deal with it and how to help our patients. I mean, in residency, right? We're so focused on pregnancy and delivery and learning how to do the proper delivery and all of these emergencies that can happen on labor and delivery. And then we learn about GYN and all the surgery and this and that. But, topics such as this, which deals almost with like medical management, right? That's what we're doing,
yeah.
trying to help out the hormones and things like that. We just don't really receive the training, and it kind of is just left to us to figure it out and how best to
Yeah.
help our patients.
And our amazing reproductive endocrinology and infertility colleagues do, right? They get that training when they go into fellowship.
Sure.
But
Yeah.
by the time, like, somebody shouldn't have to get to a specialist or
Yeah.
have to get to the point where they're having fertility troubles to know that they have a chronic medical condition.
Yeah.
So, they do an amazing job, but they're not accessible to everybody
Right.
also. And so, we need to be catching it. We need to be identifying it sooner. So whether we're OBGYNs or family medicine doctors or even pediatricians, right? Because some people it presents in adolescence, we need to be identifying it earlier.
Absolutely.
And
Absolutely.
that segues. So I'm just going to
Yeah. Yep.
segue into, big news this month. It was the release of the new international evidence based guidelines for the assessment and management of PCOS. So
Ooh.
these guidelines, this is, I don't know, the third edition, maybe there were previous editions, but it's a 200 plus page document that was prepared by, all the different international endocrine societies and different stakeholders that really lays out the guidelines of how we should be diagnosing people with PCOS and different sort of nuances in the management, answering some questions that were unanswered previously. And so if you're somebody that wants to care better for people with PCOS, then you should take a look at this document. And it's available for free. You could just do a PubMed search or do a Google search and you will find it. And so there are some really, interesting additions to this edition. And I'm going to be spending some time, today, and just, if follow me over the next couple of weeks, just talking about what some of these are, because I think it's really important. It's important for
Mhm.
physicians and patients alike.
Yeah.
And so the first sort of big change, and I've mentioned this elsewhere, is in the diagnostic criteria. So, right,
Mm.
everybody starts with a diagnosis, and there are different criteria, and it's been established by this body that we should be using what's called the Rotterdam criteria. And the Rotterdam criteria is a set of three criteria, of which somebody needs to meet two out of three. Okay. And those three things are having irregular menstrual cycles, so prolonged cycles or skipping menstrual cycles, or somebody may have regular cycles, but they're not ovulating. So that's one
Mm.
criteria. The second criteria is having elevated androgens. So either having facial hair growth, having cystic acne, having male pattern balding, called
Mm.
alopecia, or on your blood test, having elevated androgens. So that could be testosterone, but it could also be one of the adrenal androgens like DHEAS or androstenedione. And then lastly, it's having polycystic ovaries on ultrasound, which means having more than the normal number of these small preantral follicles on ultrasound. The interesting thing, and so they give some guidance as to what constitutes a polycystic ovary, so that there's uniformity for radiologists. But what's interesting is, for the first time, they've added, instead of ultrasound in adults, you can use AMH. So
Mm.
which is a blood test called anti-Mullerian hormone. And if so you can use AMH. If there's an elevated AMH, you can use that instead of ultrasound. So that's new for this year. So that really makes the diagnosis a lot easier for many people in the office, especially in places where maybe somebody doesn't have easy access to radiology, right?
Right.
Depending on where they live, or there's a waiting list, or their insurance, or whatever the case may be. And so it allows, when the other blood work is being drawn, the other labs are being drawn, that can be added on, and that'll, result in more timely diagnosis. So I think that's a really big and important addition to these guidelines.
Absolutely. So for people that may not know, what does AMH look at?
So AMH is an anti-Mullerian hormone. It's a hormone produced by the granulosa cells of the ovary. So there's two types of cells in the ovary: the theca cells, which produce testosterone, and the granulosa cells that produce estrogen, and they also produce AMH. So the more little follicles you have, the more AMH you're going to produce. Many
Mm.
people use this. I used to have patients coming into my office. They want their AMH tested because if it's low, that can indicate a problem with ovarian reserve.
Yeah.
But if it's high, that can be indicative of PCOS. So another, I used to always tell people, no, 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 we're not going to test your AMH. It's kind of not that important. It's not going to really tell you the full story. But now, for in this instance where you suspect somebody has PCOS, it can be useful.
Yeah, no, it's very important. So now let's say that the patient confirms that they have the diagnosis and they're having this irregular menses and things like that. You and I were talking offline a little bit about how that affects their sexual health. Maybe you can talk a little bit about that.
Well, certainly, because in addition to just having these markers, these elevated labs, people with PCOS experience, they can experience infertility if they're having
Mm.
problems with ovulation, irregular menstrual cycles. They can also be experiencing, people with PCOS have, two plus, 2 to 3 times higher likelihood to have body image concerns, problems with their body image or low self-esteem surrounding some of the physical symptoms that they have. And people with PCOS also have higher rates of depression and anxiety. That goes
Mm,
along with some of the endocrine abnormalities they have, and it impacts their mental health. And
yeah,
so all of these things, right? We know infertility, low self-esteem, body image disorders, and mental health conditions, depression and anxiety, all of those
right.
can contribute to sexual dysfunction, right? So it's not just one. And if they have even more than one, that's even a higher likelihood. And often they're not talking about it, right?
Yeah.
They're not coming to you saying this is what is going on with my sex life. But if they're experiencing any of those other conditions, then they're at risk. So that's something that we need to be sensitive to and asking about.
Yeah, I think you bring up such good topics. I mean, concerns I think that our patients have, and a lot of times physicians are really not equipped to answer those questions or really even feel comfortable asking them, right? Like, how many times do you go to your own doctor? Do they even ask about sexual health? They don't. At least mine don't. And so I think that, it really behooves us as physicians to really ask our patients, how this is impacting their lives. I think the other problem that we run into in medicine is that, we're supposed to see patients every 10 minutes. And so you don't even really get a chance to delve into like the deeper topics that a syndrome may be causing in a patient with what you mentioned, body image and self esteem and depression and anxiety and all of those things, because this condition definitely can cause that. I know that when patients come in and they talk about their irregular menses and they have a diagnosis of PCOS, they just really don't even know when to have sex, right? Because their periods are so irregular. And
Yep.
especially if they're not wanting to go on any type of contraception, and they're trying to conceive, they just don't know when they're ovulating, when they're not ovulating. Their periods are all over the place. What do
Or
you,
if they're trying to avoid
yeah,
using natural methods. So they really don't know when to do that. And when I was in my office practice, I actually had a few women, because that's when like all these apps became popular, right?
yeah,
All the
yeah,
apps were popularized and sort of marketed as effective contraception, which they can be if you have a normal menstrual cycle, right? And it
right.
also relies on having some data, some retrospective data. And so if somebody has irregular cycles and doesn't have enough data, there's no way that that can be a reliable form of contraception. So I definitely have seen people come in with unintended pregnancies in that, you know, thinking that they were in the safe window, or and when they weren't, because they really didn't have a predictable cycle yet. So yeah, so certainly a challenge there for people using natural family planning methods, or for those who are trying to conceive.
Yeah, absolutely, absolutely. I think that that is one of the biggest problems, and I think that something else that women complain about a lot of times with increased androgens, right, is like the hair growth that happens on the face and what to do
Hmm.
about that. And you see some women that end up shaving because they have so much hair growth on their face,
Yep,
and what I tell women is, aside from, if especially if they're not trying to get pregnant, and putting them on birth control, is to do like laser hair removal and electrolysis, because that will help a lot,
that
instead
will
of
help. Yep,
shaving.
laser. There's many different, depending on your skin type and your complexion, and so having a good dermatologist and a good uh, es-
Esthetician.
esthetician.
Yeah. I knew
Like,
it
I
was.
could read it, I can't say it. Are also really important, and, talking about the different there are other medications that can be used, but many of them you can't use if you're trying to conceive, and so but,
Right.
being knowledgeable of them, or having a good dermatology colleague that, cares and makes that a priority, and knows how to guide these women, is also really helpful.
Yeah. So I'd love to get into a little bit about nutrition for women with PCOS.
Yeah. So one of my favorite topics, one of the favorite
Yes.
things I talk about. That's my practice now, is using nutrition and medicine to help people with PCOS from a chronic disease standpoint, right? How are we managing it for the long term? And there is no one diet. Like, that's, people ask me, what's the best diet for PCOS? And it's the one that is going to make you feel good, the one that you are going to stick to, the one that, honors your religious preferences, your cultural background. But there are some common characteristics regardless of what nutrition pattern or diet you follow. So, in considering most people with PCOS have insulin resistance, somewhere 75 to 90% of people with PCOS have some degree of insulin resistance. So, learning how to manage that through reducing refined carbohydrates, including more fiber into the diet, planning the plate so that it helps with the insulin resistance. So, making sure your plate is balanced with enough protein, enough fiber, some healthy fats, so that you feel good, you feel satiated, you don't, have a lot of cravings. People with PCOS, because of the insulin resistance, often really do suffer from intense cravings. Because of increases in blood sugar and then the hyperinsulinemia that goes along with it, right? So that really can drive intense cravings. And so, how to introduce more of these foods? I'm really all about adding nutrition. I try to take an approach that is not punitive or making people feel like they're, like, really losing out on things. Like, how can we take what you're doing and just make it better and improve your diet quality? So, there is no one size fits all, but those are some common characteristics. So, getting people off their sugar addictions, and trying to get people to cook more, because when you cook more, you have more control about what is going on with your body. And everybody comes with very different degrees of cooking ability. So,
Yeah.
we start simple. Some people are great cooks, some people really are, have very little in terms of cooking skill. But when you're eating out all the time, you really have, as much as, even if you make good menu choices, you really don't have control over, what you're putting in your body when somebody else is making it. So, yeah, so it's a very individualized approach with, sort of with those basic things in mind.
Mm. So what's your favorite recipe? I'd love to have one recipe that's super easy and simple to make and that you love to tell your patients about. And maybe we can put it in the show notes for
Oh,
this episode.
Uh, God, it depends on the season. But one I love to make is ratatouille, because I think it's
Mm.
summer. Like right now, that's what I think about, because all of those vegetables, and then you can use it in so many different ways. So it's to get people think about like vegetables, and they just think about like salad, and they get bored of it, and they get, I I was talking to a patient. She was like, "No, I eat salad with chicken, but I hate it." I was like, "Nothing says like sadness to me, uh, you know, like just a boring salad with some grilled chicken on it." So, like, how can you make food more interesting? So you could take sort of a vegetable dish like that and then add it in different ways. So you can add it to pasta, you can add it to a sandwich, so that you're adding nutrition without it being really boring. So there's that one. And then if we're talking in the colder months, there's a really easy lentil soup that I love to make, and it's really easy for even the most, like, not skilled cook to do. And so, and it, like, just turns out delicious every single time. So I'll add those.
Yeah, that would be
Yeah.
fantastic. Thank you. And so I know that you recently started up a course, and if you can tell me a little bit about that.
Yeah. So the course, when this airs, we're now in September. So the course is available, and it is a 28-day self-guided course for people with PCOS. So every day there's another video, 10 to 20 minutes long, focusing on a different topic in PCOS. And it is, I cover from meal planning and basic nutrition, sort of the underlying drivers of PCOS, and we go through mental health, we go through lab testing, we go through supplements, we go through medications. I mean, really, it is like jam packed with, like, just so much knowledge that
Wow.
I've taken down, like, just sort of broken down, so that somebody who doesn't have a science background can understand it and take that knowledge and apply it to their health. And it's not a treatment, right? It's not a diet. What it is giving you the tools, the knowledge, so that you can sift through. There's so much misinformation. I go on the PCOS social media sphere, and there's so much nonsense out there, and
Mm,
there's so much predatory, um, just marketing out there,
yeah,
just preying on people's insecurities and and lack of knowledge. So it can allow you as a consumer, as somebody with PCOS, to really sift through, this is going to be helpful, or when this person is talking about this, I understand what they're saying, or what they're saying is total nonsense. So it's
yeah.
really to give some science-based information so that you as a person with PCOS can make good decisions.
That's fantastic. So, what's a common myth you think that people have that you've seen on social media that you'd like to dispel? I'm sure there's lots, but
There
how
are
about
many.
a couple? Yeah.
I think number one, that you're not never going to get pregnant.
Oh, yes.
Right?
Yeah.
So as long as there are no other factors, right? There are no other factors. Um, if PCOS is the only factor and the ovulation is the only factor, we have actually many different treatments to
Yes.
overcome that
Yeah,
problem. And actually,
absolutely.
many people, if that can be overcome, people with PCOS can certainly have a whatever size family that they want. And
Yeah.
so that's a big myth, right?
Yeah.
Number two, I would say the second big myth is that it's your fault, right? That you did something, that it's all your your poor choices in life that have caused you to have
Mm,
PCOS. So that's another one.
yeah.
And then I would say from a nutrition standpoint is that you have to give up gluten and dairy. That's another big
Mm,
one out there, and that's simply not true unless you have a particular sensitivity to those foods.
mm. Okay. Yeah. I mean, I would say that that one about never being able to get pregnant is so common, and you hear that a lot. And I think that that is one of the biggest misconceptions and one of the biggest fears, right? And I think that it makes it very difficult, especially when people don't have the knowledge and then they believe that. I think that that can really be devastating. So I'm
Yeah,
glad
it
that
can really impact somebody's relationship, right? Relationship with their
absolutely.
partner. I mean, it really is devastating until they understand what it is that's going on, and they get the education, and they get over that, those feelings and that anxiety and the stigma of talking to somebody about it. Then there's actually a lot of ways in which we can help.
And I think also, what you mentioned is the self-blame, right? With the PCOS and not, ovulating and thinking that there's something wrong with you and that you're broken and you'll never be able to get pregnant. And especially if that's something that you want, right? Obviously, there's lots of women that don't want to be pregnant,
Mhm.
but for those that do, that absolutely could be a deal breaker in a relationship. And
Yeah.
I think that that's,
And that comes from partners, that comes from family members, and that comes from the medical community as well, right?
yeah,
Just telling people, "Oh, well, if you just, go do this, like go lose weight and come back and you'll be fine." And that if you're unable to do that, then somehow you're flawed or you're at fault. And so,
right.
that comes from many different places, and our sort of like, and our thinness of obsessed society. And there's so many different layers to it.
Yeah, yeah, no, I think that that's really great. I'm so glad that you do that, and I'm glad you have the course that is out in September, and definitely people can access that and get all that knowledge that's so important. And I think what's also really important is that you're a board certified OBGYN, right? You're not
Yes.
just like some social media influencer trying to make money off of people, but rather, you're somebody that's very well educated that can give people the proper information that they need and also really give them hope,
Yeah.
right? I think it's about giving people hope and realizing that there are solutions and that it is a chronic condition, but that it can be managed and that the symptoms can be managed and you can take hold. Something that I read and I'm curious about, and actually I read it in one of my menopause books, because I'm taking the exam to get certified to be a menopause
Great.
practitioner, and they mentioned that women that have PCOS may go through menopause later in life. Have you heard of that?
Yes, people with PCOS may enter menopause sort of in their later, like the average age is 51, but many people in menopause go later into their late 50s. And so that's something that you need to be aware of. It does seem to, for some people, actually, at least the anovulation or the ovulatory dysfunction piece of it
Mhm.
tends to improve with time.
Yes.
So in the later years, so sometimes we'll see people that, or there'll be stories, right, historically, because now hopefully we're seeing people, but, stories of people who never had children their whole life, right, and then somehow, like at 45, they've been married and all of a sudden they get pregnant and they have a baby later in life. And I think maybe were those people who had PCOS, and their ovulation became more regular as
Right.
they aged. So that's possible. And then the other thing about menopause is that some of the disruptions, the endocrine disruptions, the hormonal disruptions, don't end with menopause, right? We used to think
Mm.
it ended with menopause,
Yeah.
but if your ovaries or your adrenal glands are attuned to producing more androgens, the adrenal glands continue to function, right? And so some people still may have some of the symptoms, leading into the postmenopausal years. And if you had the insulin resistance, that's not going to go away just because you go
Mhm.
through menopause, right? So
Right.
these are people
Right.
who still you need to be attuned that they have a higher risk for developing type 2 diabetes and hypertension and cardiovascular disease. So
Yeah.
those concerns are still valid and need to be followed.
Mm, very good points. I love it. So for somebody that's listening to this and would like to know how to get in touch with you, how they can reach out to you, they love it and they want to take your course, how can they do that?
Yes. So the course you can find on polyprep.com. That's POLLYPREP.com. And that's the prep school for PCOS.
Hmm.
And if you want to see me as a patient, if you reside in the states of New York or Florida, you can see me by telemedicine.
Oh,
And that website is polyprepmd.com. So POLLYPREP md.com. And or you can just follow me on the socials, Dr. Basma Faris on Instagram, also Polyprep, and anywhere else, YouTube, all the
all
places.
right. Awesome. Well, thank you so much. And thank you for coming on. And
Thank
I think that
you.
this information was so helpful to anyone that's listening because there is so much misinformation out there. So I'm glad you're out there putting out the correct information. So thank you for doing what you do. And well, I am done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you're having any issues with polycystic ovarian syndrome, make sure that you reach out to your healthcare provider. And or if you're in New York or Florida, make sure you reach out to Dr. Basma Faris. And until next time, this is the Muslim Sex Podcast. So, thank you for listening to the podcast and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So, be sure that you share it with all your friends. And thanks for listening.